Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome back. My name is DJ Wilson, of course, one of the hosts here at State of Reform. We're super excited to have you back. This is our fourth keynote, the end of day 2, and it's been frankly, a real honor this year. We've had one of the leading predictor modelers, rather, in the world, and Dr. Chris Murray from IHME at the University of Washington. We literally went out to the world for a keynote when we spoke with the foreign minister of Somalia in Mogadishu and the chief investment officer at a bank in London and international cultural commentator in Rome for our international session earlier this morning. Of course, yesterday afternoon, we had sort of breakout or a keynote session rather on some of the highlights from 2020 that included Pfizer's vaccine and some other great stories. And now we're turning to our afternoon keynote here today with some of the most well-respected folks in Washington State healthcare, people who are on the front lines leading the charge in terms of health reform and system redesign to improve the system here. And we get to talk about organizational leadership and how they are leading through COVID and what they've learned during this cycle. So with us is first Dr. Gary Kaplan, the chair and CEO of Virginia Mason. We have Ketul Patel, the CEO of CHI Franciscan, and Beth Johnson, the president of Coordinated Care Health Plan. Thank you guys for being with us. I appreciate it. Gary, let me ask you.
Thanks, DJ.
Yeah. What have you been up to this year? How have you, as you reflect on 2020, as you think about all the stuff in 2021, how do you sort of look back and think about all of the work that you have done in terms of navigating COVID? Have you had any time to reflect on the year?
Not enough, I'll tell you that much. And I'm glad you clarified, because you said, what have you been up to this year?
Yeah.
The last 7 days.
Yeah.
But really, it has been a very fast paced. So I think one of my takeaways and learnings is the speed of change and how rapid the environment has evolved and changed. And we needed to develop, we as leaders, and I think all of us in the healthcare industry needed to develop new skill sets related to navigating fast-paced, real-time change. Great example, I think, would be the team member who said to me early on in March or April, said, Dr. Kaplan, I worry, you've always been straight with us, but yesterday you said one thing and today you're saying something else. And I said, yep, that's exactly right, because the environment yesterday is no longer the environment today. And examples, in so many dimensions, like PPE. The PPE supply and PPE, supply chain look different one day from the next. And so we had to really learn about ambiguity, learn to, for me personally, all of COVID and everything that my colleagues here and across the country have been working on to take care of our patients, our first and foremost responsibility. But also to be responsive to the community, to find those areas of intersection where we could collaborate. And I've often said I spend more time with competitor CEOs in the last year than I have in the last 25 years. And from that came great relationships and great learnings. And then finally, as we'll get to, needing to navigate through major structural change and the excitement that we've had in announcing, as Ketul and I have done this week, our new healthcare system that we're unveiling here in Washington State that we're thrilled about. So all of those things together did feel like drinking from a fire hose, did feel like changing the tires while the car was going down the freeway. And I think injected a huge dose of humility along with the pride, I think, that we all feel in the great work of our teams over the past year.
Yeah, Beth, I think there's a lot in what Gary just said for all of us. What about this importance of having built social connections and social capitals with other system leaders, how have you seen that element play out in the last year or so?
You're asking me?
Yeah, well, certainly, to build on, some of Gary's comments, the relationships are extremely important. And I can't say how proud I am of the team here at Coordinated Care and the providers that we work with how resilient and adaptable and agile, people have been in this environment. Who would have thought, 2020 would have brought what it did? Just reflecting back, I have 2 kids in high school, and the last time they were in the classroom was March 13th. And as we were shutting down offices and moving things, it was, is it 2 weeks? Is it a month? Is it 6 weeks? And here we are, I'm in the office today, but we're working mostly remotely. And so just being able to, on a dime, move employees home who could move home, the hospital leaders who are on the call with us today, changing, some of the way that clinicians, were interacting. But we had to really change some of the interactions that we had with providers and community members to be able to support them differently than we have in a normal, work environment. We were making sure that particularly the health centers, the individual behavioral health providers, and all providers had what they needed to respond to the COVID environment. We spent a lot of time as a sector working with making sure that providers had laptops to be able to do Zoom calls, that members had phones and actually minutes, to be able to make sure that they could make those connections. And certainly we do that on a regular basis, but that opportunity really ramped itself up. And so it was really, how do we as a Medicaid plan and as an exchange plan and now Medicare plan, support those individuals that we needed to and support our employees. We've all been impacted, and I know, certainly again, Gary and Ketul and their organizations have seen firsthand, some of the tragic circumstances around the COVID pandemic, but there's also some good stories about that. We've all been impacted by COVID to some degree. And I think that's some of the lessons that I've learned in working with our teams and with others is life was different in 2020. And everyone had some scars, some wounds from how COVID was. And so, again, similar to what Gary experienced, it's how do we keep the lines of communication open? We actually had daily huddles, making sure that people had what they needed, getting people from home, getting even some of our team members, making sure they had the connectivity that they needed. We had to boost some internet connections, provide some additional equipment so that we could support members like we did. And then just more outreach. If you remember, even during the pandemic, we had a lot of forest fires going on. And so there was a lot more of outreach to members and outreach to providers, making sure, do you have what you need? Do you have your medications? Are things working for you? So I think it was, again, just the speed and the transparency and just the pivot in what we needed to accomplish, along with our day-to-day work of making sure that everything, gets accomplished.
So Ketul, what was your North Star leading CHI Franciscan, given all of the speed, given all of the change, given all of the scars that we accumulated in 2020, when you were leading CHI and you were thinking about, on the one hand, PPE and the safety of your staff, and on the other hand, sort of major structural realignment, like we'll talk about here in a second, how did you sort of keep it? What was the thing that oriented you as you were navigating those issues?
So DJ, I think, many people know about this, that CHI Franciscan is part of a national health system named Common Spirit. We're the second largest health system in the country. And there's so many interesting things that happened in 2020 as the country was trying to understand what the pandemic meant and, how it was going to evolve, how to take care of, our patients as they're coming in and out, ensuring that we've got the right kind of testings, et cetera. Making sure that we're working with the governors in different states. Common Spirit was almost an incubator. We were in every single time zone in so many different states, working with different governors and community leaders all around the country. And we happened to, for us, we were the first, as far as Common Spirit, to see the first inpatient case on February 29th of last year. And our life has changed. I mean, I don't want to reinforce, if you will, some of the things that Beth and Gary has said, but you just look at the journey that we've gone through where there was a lot of anxiety in February, March, and April about what does this mean? How do we take care of our patients? Should we, have masks when you go here or there? Those type of things. And I think not only did it affect certainly our patients and our staff, but also specifically all of us in how we handled our day-to-day life. But to me, I think coming out of this, frankly, I've never expected anything like this to happen in my 25-year career. I've been in small pockets of things in life. When I lived in New Jersey, we had Superstorm Sandy that lasted a week. I lived in San Diego when 9/11 happened, and a large military population with the Coronado Bridge having to be secured. But now you're looking at a pandemic that's lasted almost a year, and we know that it's going to last longer. But I really want to touch on something that both Gary and Beth talked about, which is very specifically around the pandemic is going to drive us to change how we, provide care. Just give you two small examples. First, we were only seeing 10 patients for virtual visits per week at CHI Franciscan. Now we've seen almost 250,000 virtual visits, which, I think our consumers and patients were demanding us, for years to do something differently in terms of approach. The pandemic is going to take us there. That's the one thing. Second thing is, even though, we are all healthy competitors, if you will, from a provider perspective, I can't tell you enough how I'm just touched with how, all of our leaders have been very collaboratively working together to find solutions. As an example, we've, as the vaccination program, if you will, started around the state, we've all shared doses when we needed to. If there was other organizations that didn't have the supply that they needed, over time, we've shared PPE when we needed. Gary and Virginia Mason, from time to time, we helped each other with testing capabilities, et cetera. So I think that is so unique in this state, and just, again, being part of Common Spirit and seeing how other organizations have worked around the country, I don't think that I have heard the kind of collaboration that we have here elsewhere. And I'm just so proud of, one, being on this stage, if you will, with people like Gary and Beth. I mean, we've really armed together to find a solution and not worried about historical friendly competition amongst our organizations. So that, to me, those are things that, just to add on to what Beth and Gary said earlier.
Yeah. So Beth Noel-Ray asks about the kinds of changes that were made over the last year that will be carried into the future. I wonder if you could specifically talk about the telehealth piece that Ketul brought up. There's an active conversation about what the right size level reimbursement of telehealth should be vis-a-vis in-person reimbursement. Do you want to maybe just bring us up to speed on how you're thinking about the reimbursement question moving forward?
Sure. Yeah, no, absolutely. And it's been at the forefront of everything. We saw, as I mentioned, I guess it was April, May, when, primary care visits and elective surgeries were dropping off, to protect people from exposure to COVID. We saw particularly on the behavioral health side. I have a mind-blowing statistic for you. Nationally, we've seen during the pandemic an increase of 1,500% in telehealth visits, and here in Washington, closer to 1,800%. So, similar, I think, to what Ketul was saying, that is something that we can't lose from a convenience and an access standpoint, particularly from a Medicaid, perspective, where there might be transportation issues, childcare issues, or things that, this is a great option for people to use. Certainly in-person visits are needed for the vast array of services. But it's certainly something that we're advocating that continues, that we fairly reimburse telemedicine, that the rules are continued to be as they are, where you can have physicians who have, different licenses in different states, that they don't have to be state specific to that, to allow for the access in the pool of telehealth providers. We have one of our physicians who was on your panel earlier today, Dr. Usha Sankriti, who is a telemedicine provider in her spare time. And, she talks about when she would log into her queue and just having such, hundreds or more people waiting to get a telehealth visit. We need to make sure that we have other ways to access that. But I know it's something that we'll talk about, potentially the 1115 waiver, but, what ACHs can do and what we as the healthcare authority and the MCOs and the providers can do is really support the infrastructure. We actually just gave out 6 pretty sizable telehealth grants to some FQHCs to support their telemedicine platforms, because we do think it's a technology that's going to continue into the future, and we'll find more ways to build on it for specialty services and other visits that can be done outside of a face-to-face visit for a primary care provider.
DJ, that is so refreshing to hear, because I think for far too long in this country, payment policy has driven behavior that is not in the best interests of our patients, our communities, and what we're all trying to achieve. And so a continuation of payment parity, audio telemedicine visits. There are a lot of people who don't have computers, and even people who don't have smartphones that can connect. And one of the things I think a lot about, and one of the things Ketul and I are talking about as we're launching our new organization is, yes, we want to be all about quality and safety and patient experience, and we want to do our part in bending the cost curve. And if you look at total cost of care and the need to create all of the things that surround an in-person visit versus the true cost of a telemedicine visit, we can bend the cost curve or contribute to bending the cost curve, while at the same time not being incented to provide more than what's required in terms of sites of care and venues, and using our telemedicine platform that now our clinicians are so comfortable with, and they actually see advantages. I mean, I actually have snapshots into my patient's kitchen. I can tell if their sink is full of dirty dishes, and that maybe there's some issues that we need to talk about. And it's a different way of thinking, and I think it's deeply embedded in what needs to happen in the future. So
Ketul, tell me, how does VM fit into the CHI Franciscan strategy? I mean, I know you've got a good answer for this. I want you to flesh it out. Tell us how you think about that.
Well, first of all, I want to say this. Gary and I are just so proud of what we've been able to accomplish collectively as 2 organizations to create Virginia Mason Franciscan Health. I certainly believe, and to use this phrase, as a game changer in the state of Washington. You have a iconic organization like Virginia Mason Health System that's known internationally and nationally, coming together with CHI Franciscan to create what we've created. And I think it's just a great day for not only our 2 organizations, but most importantly, for the communities we serve and our patients. To get to the root of your question, in 2017, we started our strategic alliance and clinical affiliation between the 2 organizations. And part of the reason that Gary and our boards decided to do that was we wanted to get to know each other, building on some of the work that we'd already done. So we started with a radiation oncology relationship. We moved on to what was recently opened up in the summer of last year, which is a joint venture OB program at Virginia Mason Medical Center in downtown Seattle. But we have found over the last couple years, and certainly over the last year, that we can do greater things together. Just to give you a sense of that, we have over 300 sites of care all throughout the state in the new organization, Virginia Mason Franciscan Health. When you look at that as a platform of being part of a $29-30 billion system in so many different states, we feel that as we start talking about bending the curve, creating new access to sites of care, being innovative in our strategy to if you will, going to the patient to provide care, we think this new organization is going to be the incubator for the design of that in the future. Again, this is our first week. Gary and I have spent a lot of time in terms of communication around this. We publicly released that we are one organization on Tuesday, and we've got a lot of work ahead of us to bring the 2 organizations together. But I know Gary's going to have a lot of words on this, but we are really excited about the direction that this creates for us for the future.
Yeah, good. Gary, let me come back to you for just a second. Because I know some people, well, let me sort of speak for myself. I'd say, I think it's empirical that the VM quality measures are top of class in the world. I think it's empirical that and self-evident that VM has committed to the Toyota lean production model and implementing that in a hospital setting with great results, worldwide acclaim. And I think it's pretty empirical at this point that where you see consolidation in healthcare, particularly amongst hospitals, you often see prices go up. I know you're committed to not having, to being a low-cost provider. You've demonstrated that for a couple of decades, multiple decades. So how do you sort of reconcile the sort of trend of consolidation leading to higher prices with this commitment that VM's had?
Thank you for that question, because you're giving me an opportunity to counter so many things that I personally have said in the past. And one of my favorite sayings really came from my father is, I reserve the right to be smarter today than I was yesterday. And I don't in any way regret the platform that I've had to talk about independence and to say many of the things you just said, particularly about consolidation raising prices. But that's not what's driving this joint operating company, this new healthcare system that we've created. And we have. Yesterday in our town hall for all of our employees, our 18,000 employees now that Ketul and I had, I said, Virginia Mason Health System is no longer, and CHI Franciscan Health System is no longer. We are Virginia Mason Franciscan Health, one organization, and we are going to face the marketplace that way. And as we do that, and thanks for the kind words about Virginia Mason's results, outcomes, traditions, recognition. We believe, and I've long believed, that the pathway to higher quality, safer care, better patient and team member experience is the same pathway to lower cost. And so that's what this is. When I say we're going to bend the cost curve, it's actually realizing, building on the best of both organizations that we've brought forward in our over 220 years of combined legacy, taking it in the form of a new healthcare company where we can actually realize that vision, higher quality, safer care, better patient team member experience, and lower total cost of care, and make that a reality. That's what the Virginia Mason production system is about. And that's, I believe, I'll let Ketul speak for himself, but why CHI Franciscan and Common Spirit have said VMPS, or whatever we call it in the long term, will be the management system for this new company, because that vision is shared. Now, just because the words were said, it didn't mean we believed them 2 or 3 or 4 years ago. But today we do. And today our board, which is made up of 14 people, community leaders, half nominated by Virginia Mason and half nominated by Franciscan and Common Spirit, that's their belief system as well. And so I think we can pull it off. And I think that's the promise for today and for the future. And if that's not what we are about in healthcare today, we're, I think, following the wrong path. So full speed ahead.
Well, I love that you are a value-driven leader, Gary. So I appreciate all that. Beth, let me ask you. You've been sensitive to this cost topic, this price topic, this per unit cost topic
Sure.
for a long time in a lot of different capacities. We're still going to have to deal with that after we get through this COVID situation. But it does seem to me that COVID has both elevated the financial precariousness of a lot of providers, and it's sort of elevated how, some sort of capitation model or some sort of advanced, value-based payment model could be a real tool to support providers. What are your thoughts on how COVID will change or catalyze payment reform?
Yeah, no, I think it's a great question, DJ. And I agree. And kind of to the conversation we just had about telemedicine, I think the COVID pandemic was a flashpoint for telemedicine, and we've seen that really increase, and it's not going to change. And I think it's the same thing with how we look at payment and value-based, agreements, particularly in the government space where there's fixed payments, Medicare, Medicaid, and others. that we have seen an increase in value-based agreements and a willingness for providers to work with us differently. When you see your utilization decrease and then you're in a fee-for-service environment, it puts a little, challenge in your financials. And so we actually did work particularly with a lot of providers over the summer in putting capitation arrangements in place so they were protected from a downside in utilization. And it puts that platform together to, as Gary said, to lower the total cost of care. Telemedicine being a component of that, other ways being a component of that. So we have seen greater interest, and we're actually, very engaged in that. And I think you're right that this has been another flashpoint to take a look at what makes sense going forward. And we don't necessarily want providers to have to worry about other circumstances like this. Like I said, it wasn't just the pandemic, it was fires, it could be, other, natural disasters or emergencies. We don't want to see cash flow dry up because utilization has gone down. And so how do we put something different in place that aligns incentives? And we have a really high percentage of our membership on capitated arrangements with quality incentives. And fully 85% of our members to conform with the healthcare authority's direction on where they want to see value-based payments in some type of arrangement. So I think we're all recognizing that the fee-for-service isn't going to sustain us going forward, and it allows for the things that Gary and Ketul are driving forward with their organization. Is how do you take care of a population? How do you make sure that you can care for them in various circumstances and situations, and refine your approach depending on the population, depending on the geography, and having a lot of tools to do that. So I'm encouraged that this is going to, and actually has been, changing our conversation with providers and how we do that.
DJ, I'm sorry, if I could just add, I think we can all see how that Beth is such a fabulous leader. I mean, we have Gary, being in this community for a very significant number of years. We all know that Gary and Virginia Mason have spoken about value for a number of years and actually spent a lot of time developing strategies around that. Franciscan was built differently, and but I will tell you that now, as a combined organization, we're going to continue to focus on those strategies moving forward. And I think that what the leadership that Beth has taken, we need to make sure that all of our healthcare leaders are saying the same things around that. Having lived in San Diego, which was highly capitated, the reason that San Diego was so highly capitated is you had everybody moving in that direction. And I think that coming out of the pandemic, knowing that our cost structures are in a certain place, or labor costs are rising, et cetera, et cetera, et cetera, it's going to force us to be creative. And I'm hoping, much like Beth has said, that through all the collaboration that we've done through this pandemic, it's just another great opportunity for us to unite and say, how do we reshape healthcare in this state and be a model around the country? And I think that's where, I hold that level of responsibility for myself as well. So thank you, Beth, for your words. They're fantastic.
Oh, thank you. Yeah, agree.
Ketul, let me ask you about a key piece of hospital operations, which is, of course, the workforce, particularly nurses and mid-levels. And I wonder if, like, we are going to think differently about payments when we get on the other side of COVID, or as we continue to move through it, if nursing shortages are one of the biggest barriers to navigating through this COVID period, how do you think CHI Franciscan, or Virginia Mason CHI, what is it? I'm sorry, it's Virginia Mason CHI?
Yeah. Virginia Mason Franciscan Health.
It'll soon roll off your tongue.
Yeah. Gary and I have been practicing that all week. Yeah.
Good. I will readjust. How do you think Virginia Mason Franciscan Health is going to think differently about its workforce, from development to training, telehealth, et cetera? Any thoughts?
What's been so interesting, again, there's so many interesting points that have happened in the last year, and different challenges at time. I think you remember one of our biggest challenges in the beginning was testing capabilities, right? And we have been slowly able to resolve that. Our biggest crisis right now is staffing. Our numbers in terms of COVID inpatient cases have increased month over month in October, November, December, and now January. We've had to be very, very closed, if you will, in terms of having a number of beds open in the last few months, because of the fact that we couldn't find staffing. The fact that we are a larger health system in the state and certainly nationally, we've been able to draw resources from around the country to be able to come here. But now everybody is challenged for, getting travelers, nurses to come, no matter what kind of economic value you put on bringing travelers and nurses here, it's very, very difficult to do. What's going to force us to do is to create new educational opportunities, try and train our own. We did this, with more medical residencies, if you will, at Franciscan. I know Virginia Mason has quite a bit of them. We're going to have to do a lot more of that locally and also in partnership with the great educational vehicles, if you will, around the state. I think the other part of this is that, I mentioned earlier, labor costs are rising, and it's going to force us to think a lot more creatively around staffing. Several years ago, we actually started, having televisits and actually telesitting, if you will. We had virtual sitters that were, helping us staff our inpatients for those that needed a sitter in their room. So we've been creative historically within Franciscan, but now we're going to have to do a lot more, because I just don't think that coming out of this pandemic, we're not going to see the kind of love, if you will, to come into that type of occupation, given what it's caused in terms of fatigue and just constant issues around the pandemic. So we're going to have to be creative. And I think it's a great question, DJ. Goes back to my point. We all have to work together on this, because I think we're all affected by the nursing and staffing issue all across the state of Washington, actually nationally as well.
Yeah. Beth, let me ask about Medicaid. And in terms of structure and policy as we come out of COVID, as one of the 5 MCO health plans here in Washington State, the 1115 waiver is up for renewal here this year, and the accountable communities of health, they won't go away, but because they're in state statute. But we got a lot of stuff that is on the table for renegotiation in that waiver. What do you think the lessons out of COVID are that ought to be applied as Washington State Medicaid renegotiates its waiver?
Sure. I think there's a lot, and I recognize they're applying for a year extension as a first way to do that. And I think what's certainly, we've learned, we knew, and was emphasized during COVID, is that there really is a critical need for a fundamentally better approach to support people who have the complex chronic conditions through a better integration of physical and behavioral health. And that need has become more acute. We've seen the dramatic increase in behavioral health and substance use needs. We've seen, we do a lot of training, and we've had providers request our suicide prevention training, our trauma-informed training, because people are traumatized, during this time. And so I'm hopeful and I'm confident that we'll be able to work together with the Healthcare Authority and the ACHs to really, amplify the behavioral health, the health equity issues that we really as communities need to pay attention to and that have come to the forefront. And the ACHs, I think, are uniquely formed to be able to help us. Certainly, I think it's a collaborative effort. I don't think we can each do it on our own. And so it is going to need to be a collaboration with the MCOs, the providers, the ACHs, and the Healthcare Authority. But I think we've all just underscored the need for paying attention to health equity, behavioral health, substance abuse. And that's where I think we can and should focus going forward.